I just want to thank all of you for coming in today for this session. I'm really excited about that, and I'm really want to thank all our panelists. We have the greatest, so I'm really excited about that. And without further ado, I will ask our brother, Sami Ngetich, to open for us with a word of prayer.
Economic depression and weak and changing political leadership, they were made by doing this hard thing. Greece closed schools on March 10th.
Please mute your phone if there's music in the background. Mute yourself. Yes.
Okay.
Pastor Ngetich.
All right, let us pray. Eternal Father, this evening we want to draw together as we come to listen at your feet, that you may be able to put words in many of the brothers and sisters that will speak to us. It is your will that we may prosper in our bodies, in our souls, and in all our health. And so may this day, as we bring our thoughts together, particularly during this time when we have this pandemic that is causing us a lot of anxiety and depression, Lord, we may be able to understand how to mitigate many of the factors that seem to aggravate and exacerbate this situation. Bind our families together, and each of the family that is here represented, Lord, may this day derive hope that can bring healing, hope that can transform our marriages, our families, and our loved ones. We ask that your will may be done even as we listen at your feet today. And at the end of it, we may say it was good to be in the presence of God. This is our prayer in Jesus' name. Amen.
Amen.
Amen, amen, amen. Thank you so much, Pastor Ngetich. And that is older brother to Dr. Enos Ngetich. So we'll just go in that order. We're going to ask Dr. Ngetich to introduce yourself. Please tell us a lot about yourself.
Well, I just want to say hello to everybody. This is my first time actually coming on board, and I'm so excited to be joining forces with the rest of you that are well seasoned and perhaps done several of these. I just have to applaud everything that KESSA is standing for, and thank you for the organizers for this. Not much to introduce about myself, except that I'm a married man to Elizabeth Ngetich. Got 3 children, Keegan, Cherop, and Chebet. Still quite a young family, and so I'm quite at the middle of things here.
Okay.
Beyond that, I don't know what to say. I'm pretty much a primary care provider for Cooper Green Health Services. I do primary care. I've done it for a while now, maybe about 6 years. Prior to that, back in Kenya, I was a school teacher in high school, teaching biology, chemistry. And I think my life is just very brief and simple. I don't know what else, unless if somebody has a question to ask about myself.
Okay. Thank you so much, Dr.
You're
Yes.
welcome.
Thank you, Dr. Ngetich. And you are in Alabama, right?
Yes.
Yes, he's in Alabama. Dr. Ongeri?
So good evening, my name is Moige. So I'm here, calling in from Greensboro. I'm a professor at North Carolina A&T State University. So I'm a physiologist by training, but I do research, biomedical research with a focus on kidney disease. And if you've been paying attention to the news, you know that diabetes is the leading cause of kidney disease, and people who have diabetes have really had severe COVID-19 and higher mortality rates. So I'm happy to be here and to just share the things that we can do to mitigate this pandemic.
Thank you. Thank you so much, Dr. Ongeri. Dr. Mwalali?
Good evening.
Good evening.
Yeah, yes, I'm Dr. Mwalali, and I'm in North Carolina. I'm in Durham. By training, I'm a physician, a specialist obstetrician and gynecologist, and also a specialist in reproductive health. Previously, I've taught at the University of Nairobi, and also served with the UN in different agencies, including WHO, and also served in Kenya at the time when the HIV epidemic was coming in. I've worked in several countries in Africa, and I'm grateful that you have this session. This is my first time to attend this, and I think it's a good forum. I'm married with 4 boys.
Thank you so much, Dr. Malali. For those of you who have not really interacted with Dr. Malali, you know, the stories that you used to hear is a top gynecologist. And yuko nyumbani, people used to say, kama unataka kuzaa, enda kwa Dr. Malali. So women will be told, come on, if you want to have a baby, go to Dr. Malali. So people thought it was actually him, but it was a medication that he was giving, prescribing. So he was called the doctor who helps women have babies. It was not
Right.
So Dr.
Yeah,
Malali.
that is true.
Yeah. You still do that, right?
Oh yeah, I still do that actually. Investigation of infertility was one of my yes. So that is why I was nicknamed.
Okay, thank you so much. Dr. Kanyari, Dr. Naomi is
Hello.
right there. Good. Yep.
Sorry.
That's okay.
Sorry, I was muted. Hi, you all. I'm Naomi Kanyari. I'm a hospitalist, nurse practitioner. I work at Keneston Hospital, that is in Atlanta, Georgia. I also have a medical clinic that I serve mostly rural community, especially our community. And I've been doing this, I've been in medical field for more than 20 years. I started my career in Kenya. I used to be a nurse in Aga Khan Hospital. I worked there for 10 years, and I've served in this country also in the same capacity in medical field for about 20 years. This is the first time to be in this forum, and I hope I will be able to give what I have. I'm married with 1 child, a young mom.
Thank you so much.
I really love serving our community. And that's how I ended up opening a clinic. Because when I graduated and I joined the hospital, I worked mostly in the emergency room. I came to realize that most of our people are heading up to emergency room due to conditions that are preventable. And that's how I ended up opening a clinic together with my husband. Thank you.
Thank you so much. Thank you so much. I've had a lot of good things, and thank you. I met Dr. Kanyari through Global Prayer Network, where she was sharing her testimony there and the good things that she does. So I appreciate all the work that you do. I'm going to hand over to my boss. That's what I call him, Dr. Patrick Mose. Oh, can't hear you. Okay.
Hello, everyone. I got so comfortable to an extent that I forgot I was supposed to unmute. Okay. I would like to take this opportunity to welcome everyone once again. My name is Patrick Mose, and I'm the Vice President of KESSA. Professor Gerono is my boss.
I call him my boss, he keeps me straight.
Yeah, we work together very well together with everyone here in this forum, and I'm so excited and very happy, and I feel very lucky to be associate with everyone. So feel free to jump in. There are many features you can utilize. You can use the chat function here, which is also, I know we might not get an opportunity for everyone to speak, but if you have questions on the side, you can feel free to use the chat. That is a very useful tool to use. Okay, so I'll go to the first question that for this evening. We've been hearing around that COVID-19 is affecting a lot of Black and African Americans. So my question is, why are Blacks and African Americans getting more severe symptoms and higher mortality rates?
So each of the panelists can take at least 2 minutes. We'll start with Dr. Ongeri, because I can see you at the top there.
I was waiting to see who he wanted to take the question.
That's
So,
true. We're a good team here. We work well together.
okay, so first we need to understand what are the conditions that make COVID-19 more severe, then try to interpret them in the context of what it is that Black people are exposed to or what environment do they live in. So clearly, if you're older, if you have pre-existing conditions like hypertension, diabetes, you're going to get more severe disease. If you, we have some research that's come out recently showing an association between a molecule called angiotensin 2 that's involved in the regulation of blood pressure. So obviously, if you have hypertension, it means you have more of that. It seems like the virus tends to dock on it, which allows you to get into cells more easily. And there was another research that showed recently that if you have vitamin D deficiency, then you're more likely to get severe forms of COVID-19. Then think in the context of what we Black people have. So we have a lot of health disparities to start with here in the US. So we have the highest, among the highest rates of type 2 diabetes. Obesity, of course, is the leading cause. So there's, that's already a pandemic in this country. So when you look at Black people, we already have higher rates of that, whether it's because of culture or it's socioeconomic issues, lack of access to healthcare. So it's already putting you in that bracket. Then you look at hypertension, that's also very prevalent in the African-American community. Part of it is genetic, part of it is the diet and lifestyle because of lack of facilities for exercise and things that mitigate that as well. So when you combine all this and then think about how the virus is spread, if you live in a crowded place, it's very hard to social distance. So when you think of the social injustice that has happened in this country for a long time, African Americans tend to live in the cities, the big cities that are more crowded. So it's much harder to social distance and then think about where they work. So if you're socioeconomically disadvantaged, you're going to be more in the essential services sector. So these are the people that are in the front line. You can't say, I'm not going to work. Most of us are lucky to work from home, but we don't have that. So if more of your people are working these essential services, they're bringing that home to their families. They're exposing their grandparents and older parents. So it makes sense that you are seeing very high rates of COVID-19 in this population because of the things that I just listed. And when you think about vitamin D also, it's known that Black people in general have vitamin D deficiency. So you really have to go out of your way to make sure you're getting more exposure to the sun because that's how you make your vitamin D, or taking vitamin D supplements. So it's not anything that's really anybody's fault. It's just that we have more melanin. So the sun is what helps us synthesize that vitamin D. So the fact that we have Black skin puts us in that bracket that's more likely to be vitamin D deficient. So we have a variety of factors. It's not one or the other, it's just that combination.
Thank you very much. Anyone else can jump in, please. The rest of the panelists, please.
Sorry, I was muted. I think I would also add on when it comes to immigrants, they fear to go to emergency rooms. We are very good at self-treatment. We treat ourselves so much, just like the way, especially as Kenyans, we were used to treat ourselves back home. We also do the same here. So by the time people present to emergency room, they're already very sick. So if our people can be able to seek medical care in time, and also, you know, they fear that most people, they fear when they go to emergency room, they are going to be asked for immigration status. They are going to get a big bill. They are going to this and this. They have so many reasons why they don't want to seek, or they fear to seek medical care in time. So I think that also has something to play role in why Blacks we are not seeking medical care in time. Thank you.
Just a little bit of an additional point, particularly on the school of thought that Dr. Ongeri was talking about. I work in an indigent care facility, so almost maybe slightly more than 90% of my patients are Black people. So these are my buddies, I should say, that I see them every day. It will be amazing to see that even in initial visits, when I'm seeing patients for the first time, how seriously sick they are with all the comorbidities of obesity, diabetes, high blood pressure, which has now progressed into, kidney failures and all that. They come with acute kidney disease, name them. And so, the new studies are showing that the COVID-19 virus seems to be actually affecting the vasculature, perhaps even more than anything else. In fact, most of those that are working in pulmonology clinics, even patients with ventilators, they are beginning to realize that much of the impact that the virus is actually laying is within the cardiovascular system, perhaps even more than pulmonary. And so, as Dr. Ongeri alluded, the S2 is not just present within the lung parenchyma, but it's also there in the vasculature. And so you can imagine a patient that is having chronic issues of diabetes, obesity, hypertension, acute kidney failure. Their endothelium is already having serious issues, all right? And then now COVID-19 comes in and zaps into the S2, which basically just makes the entire endothelium to dysfunction. And so it's not a question that, in fact, one of the studies I reviewed actually say that even young people, within the ages of, 30s and 40s were actually having unexplained strokes at home. In fact, most of them were being picked by paramedics when they had already died and they were just taken to the morgue. Of course, under the crisis we're having right now, there were not many opportunities for autopsy to be able to understand things more clearly. But I think we are now understanding that when people come with all these comorbidities already, and then COVID-19 comes in, it basically just worsens a bad situation. And the first thing that happens is because of endothelial failure, then the whole cascade of blood clotting agents begin to come in place. In fact, as we understand, the S2 basically runs the whole show as far as the release of, I think when you look at the whole thing about angiotensin conversion system, where the renin comes in, and then of course we have angiotensin 1 from angiotensinogen, and then of course going to from 1 to antigen 2. Then of course what happens here is that because of the absence, because basically what coronavirus does is it basically nullifies the effect of the S2, and when that happens, then there's no conversion into angiotensin 1,7, and when that happens, therefore, we basically have the concept of vasodilation of blood vessels, becoming an issue. And ultimately, what happens here is because of the vasoconstriction of the blood vessels, then the blood pressure goes high, and then we have pulmonary edema coming in, and then of course we have the whole system of breathing mechanisms affected because of pulmonary edema and all that. And so all these are, and the clot factors of course come in place, and soon the patient basically is throwing clots left, right, and before they realize, the patient is already having strokes and all that. And so I think the comorbidity is basically among the Blacks, which somebody alluded. I mean, Dr. Ongeri said about the Black people leading in the parameters of all these diabetes and hypertension and obesity. They are just vulnerable right on the onset, and so comorbidities basically become the risk factors for which it becomes very easy for them to quickly succumb to coronavirus. Thank you.
Thank you very much.
Just to add to what my colleagues have said on this, I think to start with, as even before COVID was here, there is that disparity where the Blacks have more morbidity, and therefore, when COVID comes, being a disease which of course capitalizes on the condition the person has, pre-existing condition, then it goes without saying that you'll find the Blacks are likely to be more affected. And there's also another thing I just to add to what has been said so far. It is also possible we need to examine this fact that there are quite a number of also Blacks who might be working in areas where they are likely to be exposed to HIV, to this coronavirus. And therefore, if of course they are exposed, then the chances are that the transmission goes and it is likely to go to the relatives who happen to be Blacks, and that's another factor which you cannot overlook. The question of smoking has been associated with ACE2 a lot. And the smoking amongst the Black community is a little bit very high compared to the rest of the population. So that is one of them. And about going back to the young population who are being affected by stroke, of course, that would be understood given that previously, or the first thing which was said about COVID-19 was that it caused fibrosis in the lungs. But from postmortems, it has been shown that it has got something to do with the blood vessels, intravascular coagulation, and thrombosis. And that is most likely what is causing the strokes in the young people. So that is what I can add to what my colleagues have said. And I think this means that we have to intensify education to our community, because in quotes, when we say it is more in the Blacks and African Americans, we are included in that category. And it means we have to really take it seriously and educate our communities. In fact, it's very sad when you go around in the villages and you see how the Black Americans are mixing and interacting almost freely as if there is no distancing. And even most of them not using masks. Then of course that is worrying. So there's need to intensify education, knowing that with infection, so long as there is a foresight of infection, the pandemic will continue. So you have to look at those ones who are not taking precautions because they are the ones who are going to keep the infection longer. So that's what I have.
If I could add one thing, what Dr. Kanyari said about people not going to seek medical, to see the doctor when they're sick, some of it is really not their choice. What we are seeing is the product of social injustice that's been going on for a very long time. So, and it's almost systemic. Like when you look at health insurance, you're not going to see a doctor if you don't have health insurance. So a lot of the people wait until it's really serious and they go to the emergency room. And so you see this fight trying to break or to take away the Affordable Care Act, which really extended insurance coverage to millions and millions of people. So all of us, like he said, when we think about Blacks, many times we tend to think, oh, it's African Americans or indigenous to the US, it's not us. It's us and our children.
Yeah.
They're also going to be facing these things. They're the ones who are going to face that discrimination or whatever it is that's going on in there. So we have to join the fight. They fought in the 60s to get the civil rights that really enables us to enjoy the rights we have now. Health equity is the social justice issue of our time. And I really want to repeat that. This is the issue that we have to come together to fight, to increase health literacy, to fight for equal access to health. Because if we don't have that, no matter what else you get, you're not going to be equal. We're not going to have equal opportunities.
Just to the last which Dr. Gary mentioned about the socio-economic injustice. I would, if you have a chance, you can view a video which was developed by the World Health Organization trying to explain why Mrs. X died. And the video actually is named, Why Did Mrs. X Die? And they went through all the studies, and at the end of it, it showed that Mrs. X did not die because of her own cause. She was led there by the socio-economic status she was. It's a very interesting video.
Thank you very much for the first round of questions. While you are contributing, there are some questions that are rising from the chat. And one of them is this from Dr. Shuri. We've heard and noted that COVID-19 has not exploded in Africa and Southern Hemisphere in that manner, in the manner that it has in developing world. So what is it that you perceive to be working well or certainly helps our continent and keeps coronavirus from not impacting our people? Anyone can jump in from there.
That's an interesting question because I was talking to a friend who is in Kenya and we were discussing that today. Anytime there's an infectious disease, there's going to be a lag of time from where it started. It was in China and here in the US, we were really happy it's not here. And we just watched what was going on there thinking we are not going to get it. So when you think of where it started, it's people coming from outside countries who are bringing it to Africa. So because they closed the borders, right now they didn't have as many cases. But if you look at what they're doing to control it, it's not effective. They're getting infections, the rates are going up. It's going to get to a critical stage where it's just impossible to control it. Then you're going to see that big wave of hotspots arising everywhere, and then you'll be like, oh, what's going on there? So let's not relax and say it's not going to affect Africa. We really need to be to enforce to make people aware that it's coming. It's not just the president making things hard for you, because you see there's even the way they're implementing these policies in like Kenya versus Tanzania. The Tanzanian president is acting like just life as normal. It's going to reach a critical stage where they're going to have so many infections and then they begin to spread it throughout Africa. So we are not safe. We are not safe anywhere. It's not that we have anything that can mitigate it and make it easier just because we're in the South. I don't think so. Look at what's going on in Brazil. Temperature-wise, they're almost comparable to us. But maybe because they had more travel coming in earlier, they got really higher cases and it's spreading really widely. It's likely to happen in other Kenyan, African countries or cities the same way, just a matter of time. So we can't afford to sit back and say it's not going to be there.
Okay, thank you. So I'll go to the second question. Go ahead, please.
That is, I think we also have to know that access to testing is also going to influence the kind of numbers we are seeing. And when you look at how accessible is testing in some of the African countries, it is very much behind other areas. So that also is another factor. We cannot say they might be there. And then there's the other thing is, I think there's a lot which is not known about this COVID-19. And the fact that most of the people in those areas have suffered from other many diseases before, there might be a cross immunity between that one and the COVID virus. So I think that is something to take into account. So this is opening a big area of research for those ones who are in research. There are a lot of research questions to be explored and answered.
Yeah, and talking of research, there is also one more question about methodology that's on the chat. So saying, what is the best methodology that is reliable to conduct survey using social media to gather informative data that can address the factors that increase severe impact of health disparities among Black people and low social, economic, and cultural status? So now to the research.
So the best way, actually the future of research is multidisciplinary research. We've been in the process of writing grants left and right, and every funding agency right now is doing what they call rapid COVID-19 proposals. They have set money aside because they want us to come up with answers. The NIH has done that, the NSF has done that. Here in North Carolina, the UNC university system set out $29 million and they are reviewing grants to do that. So a lot of those grants or the research requires expertise from different fields. So there's no one person who's going to come and say, oh, well, I'll generate surveys and get questions and analyze that and get the data. There's going to be some modeling. So you're going to need computer expertise. You're going to need big data. Data analytics is a big deal. You're going to need things like wearable devices, people who can engage the community. So it's going to be community-based participatory research. You're going to have to work with faith-based communities and other stakeholders. So it's going to take teams. So the era of somebody coming along and saying, I develop a proposal, I'm going to do this on my own is not going to work. And a lot of those I really have a very short time frame. We want quick answers. So by building teams, we are able to contribute our expertise and work together to get the answers. So it's not one person, it's not one expertise, it's multidisciplinary teams that are going to be critical in solving the problems we are facing.
Just something to add to that is anytime you go into studies which involves the socio-economic status and the people's lifestyles, it's very good to involve an approach where you involve the people you are researching in that research to be part of that so that they can actually be able to respond. Because once you involve them, it is also a learning experience. As they do the study, they will discover some of these factors and they will be a source of information to the other people. So it is good to involve them, those ones we are researching.
And Dr. Malali, just beyond involving them, because the reason minority ethnic groups in the US are underrepresented in research is because of the mistrust that exists between them and the research community. You remember the Tuskegee and all the others that happened those days. So you really have to adopt culturally sensitive approaches to be able to bring them in and get them engaged.
Yeah.
So community-based participatory research, but also involve people who come from those communities who understand them. You don't want to come and say, hey, COVID-19 affects Blacks more, so we want to do research on you. It's not going to work. So you have to engage them, win their trust, and have their own people involved in that research. So that's a very good point that you made.
Okay, thank you very much. I'll go to the second question. I think we'll have more questions at the end after we are done with the first set of questions. So the second question is a very common. You might have answered a part of it. So this is the second question: are men more vulnerable to COVID, and why, if so? You can start from we can start from the other way around. Anyone who is ready to respond.
Okay, let me just start and just throw some points there. I think the studies which have been done so far in this country and also in other countries seem to be very consistent that men are more vulnerable to COVID-19. But again, this one is actually something that is a finding which is guiding on what is already known. Because, even in normal situations, even before COVID, we knew men, they are more likely to have more morbidity. They are likely to even die even earlier than their spouses. Which is always, that is consistent in all the countries. So the reason why men get COVID more than of the women, of course, that is because of the underlying conditions in the men, which are more serious. There is also an association of ACE too with the COVID-19, and this is again associated with the smoking. So men are also, men are more smokers than ladies, and that could be a factor which contributes to this. So mainly it's because of those underlying factors, and also the fact that men at any given moment you find men are older than their spouses. So again, that is another risk why there would be more. Because what it means is if you expose a couple to coronavirus, it's likely to go to the one who is older. That is something which is established. So this could be one of the reasons.
Okay, so can I add something on to what Dr. Malale just said? This is Ndege, I'm in Boston. So one of the key factors that has been found to give the association to the disease as far as men are concerned and women is really genetics, the underlying genetic factors. So if you all remember, or if you had a little bit of biology in school, there's the X and there's the Y chromosome. And for those who took a little bit of that lesson, the X chromosome has more genes than the Y chromosome. The Y chromosome is a much smaller chromosome. So there are certain genes that are missing in the men because by default, they have the Y chromosome. And therefore, the protection that they would get towards COVID-19 and probably any of the other immunologically related diseases is much, much more less as opposed to women. So there's a lot that goes into genetics as far as this is concerned. And it's not just, men being men, doing what they want to do. And, we like to do what we want to do. But of course, we want to be careful too. There's genetics that surrounds this. And there's a lot that's going on in terms of studies in this area. And, we'll be learning more as we go along. I'll leave it there for now.
Yeah, I want to comment about that. I want to comment about that. There's no study that's shown any genetic linkage. We need to be very careful about making general comments like that. So the three things that Dr. Malali said are true, that men tend to have more pre-existing conditions. They don't seek medical help as much, so they'll have diabetes, hypertension, and the other things, and they tend to smoke. So those are things that have been linked to why men have higher rates. One of the things they also mentioned in that study is that men tend to wash their hands less. So you guys listening here, we have to wash our hands. That's a factor that's contributing. So I don't know why, but it was in that study and it was surprising to me. That's not true. It's true. Check that study. That's what they said.
And let me just add on to that, for those who are familiar with HIV, it's been around for a long time. It took us a bit of time to understand that HIV evolves genetically, and there's genetic variation in HIV that leads into resistance to various medications that exist right now. We've known COVID-19 for the last 4 months. There are 40,000 genomes sequenced right now. And within those 40,000 genomes, there are certain variations that might be able to cause some of the underlying conditions. But remember, we just know it for the 6 months. The data we have is from 6 months. We have not analyzed that data in detail, and there's a lot to come. So there's a lot that we need to understand about this disease. And as we move along, public health, anybody who is probably here understands what public health means. If you lived in Nairobi, in Kenya, in the old days, you remember seeing public health people coming around and telling you what to do. That's the most key important thing. One of the key things that has failed in the US, even though they have the best system, is that we are not agreeing on what we should do in terms of public health as a whole community going forward. So that's the most key important thing as far as I'm concerned, as far as COVID is concerned. Public health, information, and people taking it in, understanding it, analyzing it individually. It's very important. Genetics is important, but we've known this virus for only 4 months, 6 months, and we'll be learning more as we move along.
Yeah, I just follow on the point which Dr. Degas just brought on public health. I should tell you that I've practiced for so many years, and I've just come to realize for all those years I was practicing, standing at the end of the pipeline. By the time people came to me in the clinical area to start treating them, they have gone through that pipeline. So I'm picking those ones as they drop from the pipeline. That's why I wanted to emphasize the point which was made about public health. And that is where I'm standing now. My preference now is to stand at the entry point of the pipeline and tell people don't get in there. Because if you get in there, you might, by the time you get to the end of the pipeline, maybe even under the most specialized hands, you might not be helped.
Okay, thank you so much. Let's move on. Thank you for your contributions. We'll come back to the,
yes.
Yeah, we'll come back to the questions again. I'm going to ask question number 3. And now that we've heard so much about men, and we'll do better washing our hands. They'll do better washing their hands. The next question is for children. Children getting infected with COVID. What are the symptoms? What are the risk factors? And tell us a little bit about the relationship with this Kawasaki disease. And we're going to start with Dr. Kanyari.
Yes, children are getting affected by COVID-19. As of April, 1.7% out of 150,000 confirmed cases of COVID-19 are children. So that's a very large, a very high number, 1.7. But unfortunately, these children, most of them, they do not present, they don't get sick, just like the way adults do. They are mildly sick. And maybe that is how most cases are being missed.
Mm-hmm.
And just like the way causes have been identified, as we discussed earlier on, most of the kids who are being affected are children who have chronic diseases. Which family are like chronic pulmonary diseases, who have heart diseases, who are immunosuppressed, those who have lung diseases. I mean, all these play a big role in infection of these children. You also ask about Kawasaki disease. I've had many people asking what is the relationship between Kawasaki disease and COVID-19. Kawasaki disease is a disease that is usually inflammatory. It's an inflammatory disease that usually causes blood vessels to become inflamed or swollen throughout the body. In COVID-19, in COVID-19, it's also an inflammatory disease. And that is why people are saying what is the relationship between Kawasaki and COVID. And they have really similar signs.
Thank you. Dr. Ngetich, do you have anything to add? And then
Sorry, I had to unmute. I think it's the same challenges that adults are facing, just based on what Dr. Kanyari said. And even adults, as we said, it appears like the basic risk factor really is comorbidities. And so, as I said earlier on, it appears as if the cardiovascular system is actually the most vulnerable and perhaps even the most degrading aspect of health in terms of COVID-19. And so just like we said earlier on, any children who seem to have some underlying issues would almost kind of lend themselves to the vulnerability when COVID-19 comes in, because it finds a system that is already struggling. And therefore, the S2, as we say, it seemed to be really the entry point through which the virus gets into, especially the cardiovascular system. And therefore, the more that happens, even with children having some robust respiratory system, remember the whole pathophysiology, that things begin within the, the luminal system of the vasculature, where once the whole cascade of clotting factors begin to be tampered with, then pretty soon the lungs begin to be affected because of clots that are being transferred, I mean, that are transported in different places, whether it's in the brain and begins to have some neurological manifestations, whether it is in the pulmonary system because of pulmonary embolas and things of that nature. Apparently, the whole circulation system becomes the vehicle through which all other systems get affected, whether it is the skin system, whether it's the neurological, whether it's pulmonology. You begin to realize that all the systems begin to experience the problems that originated within the circulation system. So I think the problem with those vulnerable children, just like adults, are sitting on the edge, in the sense that once COVID-19 comes in, then it finds a system that is no longer secure. The immune system is also down, and therefore the mechanisms of defenses are already compromised, and that's how children quickly succumb in that kind of a way.
Thank you, Dr. Ongeri and Dr. Malali. You have anything else to add to that?
Just want to add to state that while children are affected, the prevalence has not been as high. And that may speak to the fact that kids obviously are staying home. Right now, they are not as exposed, but also the fact that younger people have not had all these pre-existing comorbidities. So they are less likely to have hypertension, they're less likely to have diabetes and the other things that have already primed the body to react the way it does. So what it seems like Dr. Ngetich said, majority of the severe cases you get is really the inflammatory response. So we have a given set of children, depending on what may be their body makeup, that have that severe response because it's multi-organ inflammation that they are getting, which is making it very severe for them. So there's a subset of children who respond that way. But when you take children in general and compare them to adults, it's not as severe and they don't have as many, so they are likely asymptomatic carriers. They have it, but they're not showing these severe symptoms, so we don't know. But the few that now we are getting to see are those who are reacting in a very severe way because of that multi-organ inflammation. And in adults, it's true, it's the inflammation that's making you respond that way. So your body's been exposed to so many things. It's like you're already primed. So the AC2 is already, you have a lot of that expressed in your endothelial cells, like Dr. Ngetich said, it's still the vasculature. So children don't have that. And that's why their cases are not as many as what we see for adults.
Yeah, just a small addition on, I think that all the diseases, Kawasaki and the COVID-19 in the children are very, very close in terms of symptoms, but the Kawasaki tends to be more generalized in of the blood vessels, more generalized, while the COVID-19 it affects mainly the respiratory system. And that is, and as I finish, this is a big area of research of COVID-19 in children. So people who are interested in the research, you need to jump very early.
Please mute if you're not. Okay, our next question is, do you think COVID-19 could make the social and psychosocial determinants of health even worse, especially among the African Americans and all of us? Okay, who wants to take that? Gary, I can see you ready to answer that.
Not that I'm ready, but okay. One thing I didn't tell you earlier on, I'm now the Associate Dean for Research in the College of Health and Human Sciences. And the departments in my college include psychology, social work, and sociology. And a lot of my faculty are writing grants looking at psychosocial determinants of health. That's why I smiled, because I've seen so much of that. So it's true. when you think of people who already had issues, mental health, who have stress in their lives, and now you have this isolation, you have lack of employment, you being forced to stay home, that all adds up in how you respond. And then when you think about the ability to make that judgment, so sometimes it's so lonely, people are willing to go out there when it's unsafe. So the psychosocial factors, really, you're thinking about stress, you're thinking about mental health, you're thinking about loneliness and all those things. So whether you want to think about them or not, the impact, that's why people are eager to get out. So when they said, they're opening the beaches and stuff like that, people know it's unsafe to go there, but they're tired of being home. They're finally like, you're at least to go out, so they're going, and those things are going to contribute to the stress as well. And even when you think about poverty, generally those are the things that are already priming you to be predisposed to these other comorbidities. So it's very hard to kind of break them apart and say they belong here and they don't affect this, because they all wrap together in that. And so psychosocial factors are playing a big role in that.
Yes. Dr. Kanyari, Dr. Anna, Dr. Ngetich, and Dr. Malali, do you have anything to add to that?
I think you can only say that what underlies most of the diseases is those social psycho factors. And therefore, any disease which comes like COVID-19 is going to make those ones worse.
Mm-hmm.
Especially this particular one, because it's driven by panic and fear. A lot of, up to an extent that even those ones who are getting sick of the COVID-19, the fear and the panic can actually even compromise their immunity. They even make them to suffer more from the disease. So the first thing I would say, should it come along, then the first thing is to have the will to survive.
Mm-hmm.
Thank you, Dr. Ngetich and Dr. Kanyari. You, the two of you are practicing and you're seeing patients daily. What are your thoughts, and what should we be doing to prevent ourselves, to protect ourselves, especially now as we're being told to get out? We're in phase 2. Most of us are in phase 2 where states are easing so we can get out.
To me,
I think there's no question that there's a lot of economic push as far as easing the conditions. I think everybody would agree that it's not really that the country has done much better, that we are safe to be able to get back in the streets and all that. We have to design the fact that the government also has to balance the economic aspect as well as, of course, the medical aspect of things. So I would generally say that even as we go out and begin to, look for bread and butter, that we recognize the fact that it's still very dangerous out there. And that's what I tell my patients. In fact, I dress up. In fact, there were, health and I would say within even my hospital, that some of the infectious disease persons were trying to convince us you don't have to wear the PPEs and all that. And I look at that and I say, so anyway, generally speaking, personally, and I want to just perhaps concur with other providers who are here in that point to say that you have to treat every patient that comes in as a potential COVID-19. Because again, we understand that it takes even up to 7 days, maybe even more in some people, for even people to begin to show symptoms. And all the while they're shedding the virus. And so I would urge protection for those of us in healthcare. As patients come in, we are walking them in ways that we're trying to be compliant with social distancing, hand washing and all that. We promote everything that it is to be able to be safe. And that's the language we need to sound even to our communities, to say that don't be fooled by the fact that the government and the state authorities are beginning to ease measures of protection. I think we need to continue to do everything. And of course, as a matter of prevention as well, is to be vigilant in helping these patients be able to control diabetes, blood pressures, and all that. This is the time we have to make sure that the numbers are looking much better, whether it's blood pressure, whether it's diabetes, blood sugars, and all that. It's time that we need to tighten the numbers so that we can be able to protect these patients in the event that they come across infections.
Yeah, considering African American, we are very social culturally. So being told to stay indoors just to flatten the curve, that really is very traumatizing for most of us. Not seeing my friends in the church and that lack of interaction, considering some of us, some of the people have depression. They have not only depression, they have psychiatric issues. It makes all those things combined little worse. So some of the people, yes, they'll think about they don't have enough finance to cater for themselves. But also, when you think mentally that you are just confined in that home, you are not talking to anybody, it is very, very traumatizing. Mm-hmm. It's very traumatizing for us, especially us Africans, being social the way we are.
Could I just comment? This is the one case where I think it goes beyond Africans, because if you see the people are protesting and all that to want to open up, a lot of them, they really have psychosocial issues. So it's forcing them to come out, then they're being reckless. And it's just that feel of being closed in that people don't want to deal with. And I think it affects all ethnicities.
Okay, thank you very much. So let's bring us to our last question before we start taking side questions. There are many interesting comments and questions on the sides. The last one, what are the psychological impact of COVID-19 on healthcare workers? We've seen people talking about ourselves, but about the healthcare workers, they have really forgotten. So can you talk a little bit about the psychological impact to the healthcare workers?
Oh my God.
Okay, let me just start off, and then the others can fill in. One of the things you realize is when a new disease comes like this one, and especially with that such a strong wave of getting transmitted and getting associated with such short duration between the infection and the time of death, I think that is very, very interesting. And it is very scary to the health workers. Mm-hmm. So that is the first thing, fear. And I'm saying this because when HIV/AIDS started, I was at the climax of my clinical practice. And it was very, very, very trying to do a walk around, and going through all this. And as you go through, you know, this one has got HIV. And of course, the transmission, then we were still searching to try and know how is it transmitted, okay? So there is that, that kind of fear, which of course should be associated. We also know, and we have heard of stories where health providers have died while trying to help others. Doctors, nurses have died while treating Ebola. So this goes back in the minds of the people. And in fact, one of the pictures which was very interesting is when a number of Chinese were taken to one of the facilities in Kenya, and immediately the doctor and the nurse saw 5 Chinese coming in sick. And that was the time when COVID-19 had just been mentioned. The doctor and the nurse took off. So that means there is that fear. And I'm telling you, it is there. And we have to tell you, it is there. But in the medical profession, we are driven, people are driven by the passion of, I joined this, it was a calling, and that I have to attend, even at a time when you are risking. And of course, being in the medical profession, they tend to know the precaution to take care of them. So, I mean, so that is what humbles the health providers, because they are supposed to be ahead in knowing how to prevent themselves from the diseases.
Yeah, I would add to that. People like us who are working in the hospital, we are very scared. Every time you swipe that badge, you don't know whether by the time you are going home, you are going to contact that disease.
Yeah.
And the hospital environment is like, it's like death. People, everybody is like, if you look at people's face, they all look very unhappy. It's not like the way we used to go working, very jovial because we chose to work in this career. But so many people are wondering, did I really choose the right career to be in? They are fearful, just like the way, doctor, you said, they don't know whether by the time they are going home, they'll go home with a disease. We have also seen our colleagues who are really getting sick and staying home for so many days. They are fearing for their families. So the impact is so much more than how it's being seen out there. So people are very, very anxious, and it's not easy for us. That's what I would say.
And just what was, I think this is something which needs to be observed and to be checking, because some of the health providers is going to affect them psychologically. They might require counseling, special counseling. So I think this is something we should have in our mind all the time. When we see our colleagues are either acting in a different way, then they need to be assisted.
And I would also like to add, I've seen so many people come to my clinic asking to say, to give them a letter to say they are sick. They have high blood pressure, I don't want to work. Write a letter. I have asthma, I cannot go to work. And that's not that's not a reason for me to tell you not to go to work. So you find most of these people have stopped working. So that's a very big impact on their income as well, because they just stop working abruptly with no plan of tomorrow.
Maybe something else that I wish to add on that is, I think the biggest source of fear is normally when you're dealing with an enemy that you don't quite understand very well. And you can remember when when COVID-19 presented in the United States for the first time, we didn't really have much understanding in a number of areas. Number one, they were talking about transmission mechanisms, and a lot of that was that perhaps it's only aerosolized. Either you're talking and there's a little bit of you know moisture that comes out of your mouth, of course, 6 inches and all that. And then there were questions about whether it was also airborne. You all remember that initially, even the concept of the use of masks were being denied. I mean, a lot of authorities, in fact, came very strongly saying that the masks are not very helpful. Now, everybody is required to wear a mask. And so, as healthcare providers, you are already at the very center of the disease. You're dealing with patients that are presenting with the illness already, and yet you have to plug yourself in there to do everything that the patients need to be done. And of course, you're watching these patients dying left, right, especially in cities like New York and all other places that have been ravaged by COVID-19. And then the other thing too is where they had to make decisions. I mean, many of us were reading in the news that the ventilators were not enough. And so in an ICU setting where you're having 10 patients who are needing a ventilator, and yet you have only 3. I understand that they had to make a choice which patient gets a ventilator and who is to be left to die. I mean, literally, you had to make those kind of decisions. And so, like Dr. Mwalali said, I think there will be some trauma that a lot of doctors will have to suffer, nurses and all that, because when you have to make these choices and clearly you are deciding for one life against the other, and finally that patient has to die because we didn't have enough ventilators, you know for sure maybe the ventilator would have made a difference in terms of the outcomes. And so all these social and psychological implications of having to make those kind of choices, having to live in fear for an extended period of time, is something that I think medical providers or healthcare workers will have to deal with for perhaps the coming years.
Okay, thank you so much.
Just to go on that, Geronov. So first, I want to thank all the healthcare workers on our forum. You guys are brave, you save lives, and we thank you for putting your lives on the line. And most of the time, these guys work hard because they have this commitment to save lives. And some of them are feeling helpless watching people die, knowing that they can't save them. You guys read the story of that ER doctor in New York who committed suicide, because it really affects them. And suicide rates in the nation are highest among doctors, always has been the case. Because we have some of our smartest going on to that profession. So in your family, you're known to be somebody very smart. People expect you to be in charge. So because of that, they don't tend to seek help. They're expected to be the one solving problems. So now here's a situation that's affecting them. Some of them are living in their cars because they're afraid of bringing that to their families. And then they can't speak it out. They can't really seek help because they feel like they're supposed to be the ones solving problems, not the ones being a problem to anybody else. So it's real out there, it's really fearful, and I hope we have programs that come to take care of them, just like we had the post-traumatic syndrome for people who went to fight in the war in Iraq and other places. These guys are the front line of a war that's really very severe, and I hope that the government and others will put in place programs to support them afterwards.
Thank you so much. I want to open this session now for Q&A. I know most of you panelists, if you can look at the questions in the chat, but I think it's also good to hear your voices. So if you have any question, if you put it in the chat, let's go ahead and ask those questions. Any questions, just raise your hand and mute yourself. You can read what you put down there. Yes, Dr. Theory. Dr. Peter Theory.
Yes, it's been a fruitful discussion. My question is, Dr. Ongeri, you mentioned that there's a chance that this might not even go away, and in Kenya especially, that we have not seen the brunt of it. My question is it that our leaders are very uninformed about the severity of the virus, and that they're not taking more drastic actions to lock down or to do whatever they need to do? Why is it that we look like we are so relaxed and we're just waiting for, if it's inevitable that it's going to happen, why is it that we're still waiting? What do you think?
Okay, so I look at it in the context of a country with resources and a country with very limited resources. So in the US, they could tell us, everybody stay home. You can still go to the store and get food. You can order food, something will come to you. They could send us stimulus checks. You're not going to die of hunger. You can't do that in most African countries. If you tell people stay home, they're going to stay in and die. So they have to choose to die of hunger or go out and expose themselves at least to earn a living. So it's more really socioeconomic factors. So I think the country did the right thing when they set up those quarantine centers, because the best thing you could do is minimize the number of people coming in infected and be exposing to others. So Kenya did the right thing. The only problem is that they were now requiring people to pay for themselves. And because of that, anybody who feared they were exposed would not come voluntarily because they knew it was going to cost them money. At the same time, when in those quarantine centers, they didn't put in place ways to avoid transfecting people within that place, because they are sharing bathrooms. And because of that, if there was just one person positive, they could infect the others who live in that location. And again, Kenya immediately figured out which regions had higher rates, and they blocked people from moving to the rural areas. That was smart, actually. So we critique them and say, oh no, you can't do that, but it made a difference. They're requiring people to go home early. I mean, it wasn't implemented right. You saw all those videos of people, police beating up people and stuff like that. But it probably sent a sign that this is very serious. And at night is when people come together and they make, they're not as careful with the social distancing. So that is probably helping as well. But the truth is there are a lot of poor areas in Kenya and other developing countries. So once like it gets into Kibera, how do you social distance there? So that's why I said it's a matter of time. Once you get a critical number of people in that area infected, it's going to really go up. Uganda did the same things, Rwanda did the same thing, and I was really shocked that in Tanzania they're saying, oh, it's no big deal, it's just like a common flu. It's not a common flu, it's going to affect people, and unless every country fights, we can't win. Even the US, I mean, US can do everything and maybe we slow this, but it only takes one person from a foreign country to bring it right back in here. So African countries are trying, we just have very limited resources, and poverty is a big factor in fighting this.
Any other questions that you can direct them to any panelist? No questions?
So can I just add something to what my sister said? And this is Ndege.
Yes.
So again, I'll repeat that, we do not understand a lot about the genetics of this disease. And the reason I say that is because in Kenya, we have places that are very densely populated. Think about the urban centers in Nairobi. And one could have thought that that's one place that you could have had an explosion. And it has not happened. And we are happy that it's not happened because probably a lot of the public health measures are really helping. But this is a disease we are learning about as we move forward. It's been only 5 months since we knew about this disease. We don't know what's going to happen 3 months down the road. There'll be a genetic mutation. Who knows? Something else might happen that we'll never have imagined. So let's just keep that in mind.
Just to add on what Dr. Ndege is saying is there's a lot which we need still to know about this COVID-19. We are only a few months into the disease, and there's still a lot of research to be done. But there's something called herd immunity. Herd immunity, epidemiologists know that in fact, herd immunity is what controls a pandemic like this one. The moment there will be more people who are exposed to this and they have developed some immunity, that becomes a distancing factor, because between the infected, there are several people whom we cannot infect, between those one and the next person who can be infected. And time is going to tell, because some countries are saying by this lockdown, we are slowing that natural process of creating herd immunity. And Tanzania is one of the countries which has said, let's be a little bit relaxed, let people mix so that at least this and that. While others where you are locking up people here, you are locking those ones with the disease, and therefore they are virgin people who have no disease out there. The moment you let somebody the disease, they get infected. So there's a lot which needs to be done about this disease, but immunity is one of the things which is going to control the pandemic, and it can occur in two ways. Either more and more people are exposed to the disease and they have developed the immunity, or there's a vaccine which is going to to control that. Those are the two factors.
Just to add on, Dr. Malale, a good example here is Sweden. Sweden told people, this is a public health hazard. We are not going to control your lives. Go along your lives as you do every day, but make sure that you take care of yourself. You observe the basic public health principles. Okay, they do have a lot more deaths than some of the comparative Scandinavian countries, but they have essentially gotten over it much better than some of the countries that, have been impacted with that. And who knows whether that's the case in Kenya, given, that, Nairobi are considered to be an international center. We have so many people that travel into Nairobi from many different countries. And if there was going to be any explosion in Africa, I would have thought that Nairobi was going to be a place that, it would happen. So who knows? Maybe the herd immunity part of it is really good. And the other encouraging news about that is the current, vaccines that are kind of entering clinical trials, phase 1 and phase 2. They actually are demonstrating really good, immune response to the extent whereby when they take the antibodies from these patients and try them in vitro, meaning in the Petri dish, they see that the antibodies are able to pretty much, clear the virus from the cells that they're using to study. So there's some confidence in that respect. And let's hope that that's what's happening in real time in Africa, and that, maybe some of it's genetics that gives us also, a good, immunity to actually repel the disease. So I'll leave it there for now. But there are a lot of factors, and just the most important thing is that there's not a lot we don't know about the disease. We've had it for only 4 months, 5 months, and we'll be learning more about it as we move forward.
I'd like to address,
Okay.
there's something about innate immunity that I think it's worth mentioning even in this meeting. Of course, when we talk about herd immunity and perhaps even antibodies, as my brother implied here, we do not have acquired immunity as yet to COVID-19, because of course that has to happen after infection, okay? So a lot of Kenyans have not necessarily come in contact with COVID-19, so we cannot necessarily say that there's already herd immunity against COVID. Neither can we say that there is acquired. But there's an element of innate immunity that I think has been down, or has not really been accentuated as well as it needs to. And I want to quickly just address that in a few minutes. Some of the early studies coming from China are showing that the first immunity that gets decimated by COVID-19 virus is actually the innate, which all of us are actually born with, which includes all the natural killers and the monocytes, so much so that the people that seem to even succumb to COVID-19 are those whose innate immunity actually was knocked down. Now, there's a component of the human immune system sometimes going into slumber. In other words, we have these cells in surveillance, but oftentimes they are sort of slipping, in quotes, to the extent that the virus is already in the system, is already causing havoc, and yet it takes a while before this innate immunity kicks in. And so the question then is, how then do we trigger this system to be up on their toes so that anytime this kind of virus gets in, it's dealt with immediately? Because apparently it's been demonstrated that a lot of people whose innate immunity was awake, I should say, by the time they got infected, they actually survived. Either they never showed any symptoms of COVID-19, or if they came down with the illness, it was just mild and they were not even ventilated at all. And so when I looked at some of the studies, it actually showed that there are certain things that can be done naturally to be able to trigger this. And by the way, I'm counting on this perhaps to help Africans, because number one, there's low lifestyle comorbidities in Africa. We don't have a lot of, especially in the rurals. I know in the urban areas that have westernized their lifestyles in diet and everything are now beginning to have issues with obesity, diabetes, hypertension. But the larger portions of the rural Africa are still, they are not, transportation is walking from point A to B. They are digging, they are plowing, they are walking long distances. And by the way, all those are very protective in the sense that it keeps them having low weight. Blood sugars are always on the lower side because they're not even getting enough to eat vis-a-vis the amount of work and labor they're doing. And so I'm counting on that perhaps to be one of the protective measures that our African people, as poor as they are, might actually benefit from. But here is something else: exercise. They're not even doing exercise the way we're doing here, going to the gyms, but of course they are carrying loads of water and firewood and everything in the rural Africa. And yet that has been demonstrated to continue to help them circulate blood adequately. And then it awakens the whole immune system there's something about hypothermia that if I had some time, we could discuss about that. You know, some of the Swedish countries, countries in Scandinavian have jacuzzis and all this. And by the way, hypothermia has been demonstrated to trigger an immune response to the extent that when you elevate the temperature, you are mimicking the natural conditions that tend to awaken the immune system of the body. And so these are some of the things we can even do in our own bathrooms, taking hot showers. And then, of course, you can alternate and do what we call the contrast bath, where you're taking hot for about 3 minutes, as hot as you can tolerate, then quickly switch to cold for 30 seconds, and then back to hot, and then cold. That somehow awakens the body because it mimics an infectious situation. And then the innate immunity thrown into surveillance, and if there's anything circulating that is foreign in nature, is dealt with. Lastly, a lot of problems that Africa have, a lot of diseases that are tropical in nature, perhaps are helping some of these innate cells to be perpetual in circulation, to the extent that if a virus comes in at any time, it finds the system that is already up and running. And so with those few remarks, I want to say that it will be seen. I'm curious to see how things develop going forward. But I think if Africa exercises all the measures of public health, I think they may have some upper hand in natural protection because of that kind of environment. Thank you.
So one thing I want to add to that, so the lockdowns were not really meant to prevent, it's really to buy yourself time. This thing just came hitting us just like that, so fast. So if you don't have the ventilators, you don't have protective gear, you don't have anything, it will have spread very rapidly. So that lockdown bought time. So you can see they're already designing and buying the protective gear. They're bringing in some ventilators so that if you have the numbers going up, you're a little better prepared. So most of us are opening up now, not so much because you're not going to have as many people as before, but if we had them now, maybe we have the bed capacity, we have protective gear, we can deal with that. So I'm happy that they did the partial lockdowns and therefore slowed that and bought time for them to get prepared so that they can handle it.
Thank you so much. Thank you, Dr. Ndege. Dr. Ndege is the chair of the Diaspora University Project, so he's taking the lead on building that university in Kenya. Thank you, Dr. Ndege. Dr. Imali Abala, you have several questions. I'm going to let you ask your question. And for those who do not know, she is the editor of the KESSA Kenya Studies Review. That is our journal. So if you get messages about the review or submit your publication, that's the boss right there. So I'm going to let her ask that question. You're muted. Okay, good. Okay. Oh, you're muted.
Okay. So I had two, but I am going to only ask the second one, which was that we have heard a lot about the hydroxychloroquine as a possible cure for COVID. And so I just wanted you to kind of address some of the truths and misconceptions about this drug, and also find out what kind of advice you may be able to offer some of our people who are thinking of using traditional medicines like moringa, marubaini, and all the other medicines that I didn't include there as a possible cure or prevention.
Analyst wants to take a shot on that.
So I can. So Imari, so hydroxychloroquine, as we know, is a malaria drug.
Yes.
And we know it works very well as a malaria control drug. And one of the key things that goes into determining whether a drug will work for a particular disease is usually the clinical trials. And there have been a number of clinical trials, both in the US and outside the US, whereby hydroxychloroquine has been used with an antibiotic. And there was only one that was published at the end of, I think, February or beginning of March from France. And it was a very small population. And in that particular study, it kind of showed that it was working. in terms of, being able to reduce the caseload. But this was very early clinical trials. I think it was like probably phase 2, whereby you are really looking at the combination of the antibiotic and the hydroxychloroquine, and you are looking at, various doses in a small sample of patients. So that's the study that actually brought a lot of this story about hydroxychloroquine around. And if everybody remembers, COVID started in China, and China has been doing studies on hydroxychloroquine as to whether it is able to, treat COVID patients. And in those studies they have run in China so far, nothing has come out of it. And the studies here in the US, which are clinical trials that involve, patients that get the placebo and patients that get the real actual drug. The biggest study that was done in the US was at the Veteran Affairs, hospitals. And that study demonstrated, I think the results were just very recent, that, it was not helpful in situations whereby patients were infected with COVID. So I think the jury is still out there. But again, if you think about this in the context of, what's going on in Madagascar, I think a lot of you have been following that story, maybe.
Yes.
I think the president of Madagascar, or the prime minister, was really very forceful at the UN today or yesterday, talking about the traditional medicine that they're using in Madagascar to treat COVID. And for them, they have not seen any, they have seen very, very good response, and they have seen patients that present with COVID conditions, really getting well on that medication. So it's very difficult to actually compare what's going on in Madagascar and the hydroxychloroquine. The Madagascar one actually includes Artemisia, which probably a lot of you have heard about. Artemisia is from a plant, the Artemisia plant. They pretty much extract the active ingredient. And that's the ingredient that has been used a lot to treat malaria in many other places. So, in Madagascar, it seems to be working very well. I know that, there are some countries in Africa that have actually asked to get that. And, the president of Madagascar was very forceful about that. But as far as chloroquine is concerned, and chloroquine is a very different chemical from Artemisia, when you compare them chemically. Chloroquine has not been able to be reproduced in clinical studies. And there are some clinical studies that are still ongoing right now in the US. And we'll hear about that with time, and we'll know whether, there is any help or not. But right now, the side effects, as they say, might be worse than, the benefits, unless you are treating malaria, of course, which we know that it works very well on malaria. So I'll leave it there for now.
Just to add on to that, I think it is my hope that the researcher in Madagascar is going to be supported to go ahead and approve this, because it has been very discouraging in the past, where somebody in somewhere in Africa comes with something which he thinks is promising, and then all of a sudden that the person is demoralized and stops that. And I remember one colleague of ours, a medical doctor in Kenya, when he talked about Cameron, that one cost him his license, instead of supporting him to see whether there's anything which is valuable in that. And Artemisia is actually a herb, and therefore there's a lot which is hidden in the herbal medicine. And I'm sure Dr. Ndege, when he gets to Voi, is going to work with the herbalists there and see whether there is anything which can come good. And I will be the first one to give you one which you are going to test. And this is a medicine which has been used by our community for treating tapeworm. And this one, traditionally, the grandmothers would just go and fill a bark of a tree, put a cup of water. In the morning, if the celebrant was got tapeworm, would be given that drink. By evening, the whole thing has come out, paralyzed completely. So that is something which, in fact, is these are some of the things to try. So there's a lot in herbal medicine which needs to be tried, and COVID is opening areas of research.
Yeah.
And just to add on to what Dr. Malale has said, we should actually respect our traditional medicine from Kenya and anywhere in Africa or anywhere in the world that exists right now. And the thing about traditional medicine is this: when you go and you are given a herb, nobody takes that leaf and extracts something from it and gives you and tells you, take this. This is the part of the leaf that is going to help you. No, they just smash it up or boil it in some water and they tell you, drink it. Yeah. And so you're drinking a whole mixture of chemical entities, and most likely they are required to work together to solve the problem that you have. And that's where, the herbal medicine becomes very tricky, because once you start kind of diving in and trying to separate the molecules apart, then you remove the other cofactors or the other elements that help that medicine work really well. And this is the complexities of studying medicine that even the Western world here does not understand right now, as we talk right now. And the thing about Cameron is pretty much interferon. Interferon is very good. It's part of the immune system that is stimulated in response to infections that are coming to attack the body. And usually it's supposed to help the body mount an antibody response and immunity so that you can clear whatever infection that you have. So interferon works, so Cameron works, but Cameron alone was not enough to be able to help it. We needed Cameron and other things so that we could get that to work well.
I won't
say anything more, I'll leave it there now.
I want to say one thing about the clinical trials. I think if you want to be a player in a game, you need to understand the rules of the game. So that's the only way you win. So like Dr. Ndege just said, when you come and say, hey, we have this herbal medicine and it works, and you're telling me to sell it to the world, what are you selling? You don't have a formula, you can't scale it up, you can't have a dosage, you have nothing. And then you don't have data to show how you got to that conclusion, because the way clinical trials are done, there's a way you set it up so that you give it random to patients, and then you can be able to compare and say whether it was a placebo or a standard care medicine that's already being used. Is there an advantage? Did it do any harm? Are there any side effects? So until you have all those controls in place, it's very hard to come out and say this drug works. So because we will ask you to show us the data. How many did you have? How many were in this category? What are the things you saw? What are the side effects and stuff like that? So there are things that come out too soon, like when they had that very small number of patients, they tried that on and they quickly talked about it. And then when you try it on a higher number, you see it's not holding. And then when you say, oh, in Madagascar, we have this, but who have you tried it on? What are the controls? How do you know that it made a difference? Did it improve the number of days that they had the disease? Did it reduce the symptoms? How do you make that case? So we really need to be able to say, let's understand how drug development works, how you verify, and that's where we have so many phases of clinical trials, and that's so many drugs that get started never get to the end. So once you understand that, then you can see why we can't just jump up and say it works. You have to really prove with data, solid data.
Yeah, and the other key thing is going to be, okay, if we said that the Madagascar drug works right now, are we able to provide enough doses for everybody? Even in Madagascar itself. So if we were to say, okay, people are sick in Madagascar, we need to treat them from COVID. Are we able to provide that? Because production is a very key thing. So as we think about traditional medicine and how to use it and apply it, we really have to think of bigger in terms of, if we were to be asked to provide it, how are we going to, work through this process and actually get it to the patients once we prove that it works well.
Yeah. So that Madagascar drug, again, you keep saying you don't have a name for it. It's just a cocktail of things.
Exactly.
So you have to have a specific formula. You have to have a dosage. You have to have like, how often do you give it for it to work? You just can't come and say this cocktail works.
And so just to let people know, that field right now, it's been adopted by the Western world. It's called ecobiotics. So go Google ecobiotics. Australia is at the leading front of this. There are a number of companies in Australia that have been founded around ecobiotics because they have a lot of natural, vegetation, and they know a lot about this from the Aborigines. And they are the forefront of this. They have some drugs that are in clinical trials for cancer that are actually really being extracted from various, plants in Australia. So it's called ecobiotics. So Google it and look at it a little bit more.
Okay, because of time, I'm going to move on. There is one question for Dr. Kanyari by Carrera. Is that how you say your name? You want to ask the question?
Yep, that's me.
Yeah, go ahead and ask.
All right. So, Dr. Kanyari, so you said that kids with pre-existing conditions, like you said kids with, say, chest pain, coughing, and all that are susceptible to coronavirus. So I termed those as pre-existing conditions. So my question is, does corona affect kids with pre-existing conditions the same way it does to adults?
Yeah, it depends on the child's condition. Some kids might have asthma, but that asthma is not that serious. They might have diabetes, but that diabetes is not that bad. It's well controlled. The thing here is controlling. So the symptoms, just like what I said earlier, the symptoms that you observe in kids are milder, but all the chronic conditions that adults have and the kids have, they can get it. But the percentage of those kids is very, very small. And the most important thing is the caregivers of these kids who have these chronic diseases. If you find your child, like let me give an example, like a child has asthma, and you find this kid is using breathing treatment more often, the child has temperature, the child has more cough, and you are giving medicine, this is not going away, this is the time to take that kid to the hospital. And if you take this child to the hospital and the child is diagnosed with the COVID, after about 7 days, if the child is not sick, that child is not going to be admitted. So they'll be sent home. So the most important thing is for the caregiver to monitor the breathing of this kid. Watch if the child is breathing with their stomach, breathing very hard. If the kid is complaining of chest pain, the color of their lips. If you find the color of their lips is turning kind of blue or different, or that child feels more cold, then you know that the condition is worsening. And this kid needs to be taken back to the hospital. Don't try to do home care remedies anymore. Okay? So, thank you.
Thank you so much. Before we move on to the final remarks by the panelists, I just want to introduce our team real quick. At KESSA, we work very well. We have a great team. We have the greatest team. We work well together and we do these things together. So it wasn't just me and Patrick who did this. We have Dr. Rachel Ndonye, who is our secretary. You are getting a lot of emails from her, Dr. Rachel. Can you say hi, Dr. Ndonye? Okay, you don't want to, okay. That's Dr. Ndonye. We have Dr. Imali Abala, who is the editor of the Kenya Studies Review.
Hi.
Okay. We have, of course, Dr. Ongeri is part of a governing council too. We have I see Dr. Rachel Boyd. Can you say hi where you are or let me see you? Dr. Boyd, did you leave? I guess she left. We have Dr. Penina, I see you somewhere.
Good evening, good people. Can I squeeze my question?
Yes, you can, Penina.
It's a very simple question. Are the symptoms manifested by Africans, by Blacks, by Kenyans, are they the same as the symptoms manifested by other race? Because one of the things I heard is the mouth turns blue. Can a Black person's mouth turn blue?
Good question, Kamina.
I'm so glad you asked that, because one of the things when I teach my students anatomy and physiology, I'm like, don't go by the textbook because that's written about a white patient.
Right.
Like, find out what happens with the Black patients, because you're not going to see those. So I'm so glad, Penina, you asked that. So the doctors on the forum.
I think I can only say this. I think that static blueness is something which in the practice, people have got to know that in fact you have to assess it very well, because it might not be just as clear as it would be on a white person.
Mm-hmm.
For sure, if you have been doing it again and again, you will be able to know that this person has got some blue color, and that is what you call cyanosis. So it's possible to tell, but of course it depends on if you are trained in Africa, it is very easy for you to pick it up because you've seen it again and again during the training. But for somebody who is new, for example, if you take a new graduate from here and he lands in Africa, everybody will be having a blue cyanosis. So, so it depends on where somebody was trained. So it is easy to identify, especially if you are trained in that environment.
Yeah, if I can, Gerono, that question is so seminal to how we need to shift our mindset into the way we do research and education. We have been depending on Western thought, who studies us more than we study them, and we don't study ourselves. And this association is about Kenyanist. I like the idea of Kenyanist, but not the Kenyanism, because it's a more Kenyanism is convergent, but Kenyanist is a divergent thinking. So we need to start now collaborating with the people in back home and partner and doing research. Today we can do this research with using media like this, and then have a serious examination, exploration, and discoveries of our, for example, pharmaceutical discovery, the drug discovery. I don't hear much going except our esteemed George Joroge, and now we have a Wilson Ndege over here we are trying to create a diaspora university whereby we have biotechnology and we want to create pharmaceutical, and you find there is a kind of a lukewarm response to the people who have skills in diaspora. So I'm inviting you to start thinking and research. We do it in the KESSA. We should be sharing what is discovering ourselves, studying ourselves, because we have been studied by others, and you know that what that means. So the mindset of research and education, we should transform it and be able to find solutions with our own context, because African-centered thinking has not been the mainstay of the higher education or research in the science. So it's time to wake up.
Could I say something to Penina? So while the text, for a long time, textbooks really gave examples of white people, white patients, everything like that. We've been fighting that. The trend is changing. If you look at new edition of textbooks, you see pictures of representing different cultures, different colors of people, men and women. For a long time, medical terminology was based on the examination of the average white man and a white woman. So that's why now even when you do research, the NIH makes sure that you include women and children, that you include different races of people, because we can't afford to be basing our research and findings on data from one subset of people. So for a long time, you'll be describing blue and all that, but you have to remind your students and your patients that you're not going to look for those things if you don't have fair complexion. I always tell my students, yes, these are the things your textbook says, but if you're like me, you're not going to see that. Therefore, you need to understand what causes that blueness. So if it's because you have low oxygen and your hemoglobin, you don't have oxyhemoglobin now, so it's going to be darker. So if I was already dark, you should know yourself, know your body, so that you can see the differences or the things that change when you get sick. So this is where a parent really plays a bigger role than the doctor, because if I walk in and you see me darker, you don't know if that's my normal complexion. Some of us are darker than others. So as a parent or as a person, when you know yourself, you can see when something is wrong. When your face looks different, you can tell something's wrong, I need to see a doctor. So don't rely on the doctor, because the doctor doesn't know what you normally look like.
Yep.
So just to add on to what my sister said there and the other panelists is, and I don't want to go into the genetics and all that. I'm not a clinician, so just everybody knows that. So I'm not talking from a clinical point of view. So some of the information that has been published in the last 4 months or so has demonstrated very clearly that the COVID virus really attacks the cells, and more so the red blood cells, through the S2 receptor. The S2 receptor is in the surface of the red blood cells. And what does a virus do to the cells when it attacks the cells? It attaches and gets in, uses the machinery, divides and blows the cells off. And so what happens is that it depletes you of the red blood cells. So if this is what's presenting as the red, the blue, or whatever it is in the Caucasian population, then that's probably the case, because they're really being starved of oxygen, because the cells are not intact. The heme is dissociated from the ion, and therefore they cannot bind the oxygen atom. So in simple terms, that's what's going on. And the reason I said that, we don't know much about this disease, right now, a lot that we know about it is the scientific community has concentrated on sequencing the genomes of the different viruses, whether it's in Seattle, Wuhan, Singapore, or Kenya. That's what we are doing right now. But nobody is taking the time to look at the receptor from the different populations that, are being impacted. And maybe people are doing it right now. We start getting that information. But one of the key things that, underlies among the African population or the Black population is that, we know that there are mutations within the S receptor that present us to have, some of us among the Black populations to have more high blood pressure and all that. And, whether those mutations actually make that virus bind better, we don't know. So that's information that we are hoping that, we are going to gather as we get along. But there are a lot of things that are going on. So let's just, keep reading and, share information as it comes. Those who cannot understand it, if I share something, just get back to me privately and ask, Wilson, what were you saying? And maybe I'll try and explain and make you understand what's going on. So
I want to ask, so Ndege, just quick one, to assert, because we when you look at the science, traditionally it focuses on pathology than anything else.
Yeah.
And then to arrive to social and behavioral sciences, which shows we can predict this cause and effect. we miss it because we are following the methodologies which are again oriented to a different context of cultural environment. So if we can start looking at social and behavioral sciences, and now the chemistry, biology interact with that, we will arrive to whereby we can raise awareness and shift the mindset of people and realize, look, I have not been focusing on me, and my what I do does not reflect what I am expecting to do. So there is, and I want everybody to go look for what we call confirmatory bias in anything. And we can start testing. I would like to see a session in the next KESSA conference addressing how we do contextualize research and science as an applied field to start looking at solving the problems, solutions on our environment. Until we do that, then it's supposed to going from abstracting, coming from abstraction. That's why people don't want to, young people don't want to go into sciences, because we made it so complicated that it becomes esoteric, and they don't see how it applies to self. So I hope we can look at that and start eliminating or deconstructing the contradictions in science and research.
Okay, thank you so much. Thank you again. We're trying to finish by 10 o'clock. I'm going to give I'm going to give them 2 minutes to just say their final comments. I'll start with Dr. Enos, Dr. Kanyari, Dr. Ongeri, and Dr. Mwalali. Just 2 minutes, and then I'll hand over to Patrick to finish it off.
I think with all said, the only emphasis that I think I wanted to just add, in addition to all that we've discussed, is the value of nutrition. I think it's very clear as we look at the whole concept of COVID-19 and the outcomes that we witnessed, not just in this country, but across the world. As we talk about people that are elderly, above the age of 65 and above, as we talk about comorbidities, I think that the most central issue here that I see is the human immune system. I have looked at the way the Bible says how we have been created so wonderfully and beautifully by God. And yet we can be so ravaged by such a microorganism like COVID-19 and many others. I think it's something that would be looked at, that the superiority of the human generation, I mean, the human species, that has pretty much fallen victim of just about every microorganism, whether it's Plasmodium causing malaria, name it, that many of us begin to wonder how sophisticated God had designed man, and here we are, the masses of all these microorganisms. And so when you study that concept and kind of go along that trail of thought, you begin to wonder that I think where we began to, or where the rains began to beat us, is when we deviated from the standards of preservation of the human organism by basically abandoning the ideals of humanity. I mean, it amazes me that most of us, and I tell this to my patients, that we take care of our own automobiles better than we do ourselves. You know, I take care of African Americans mostly here, and you should see the kind of cars they are driving to come in to see the doctor. You know, and they are not never late taking those vehicles for oil change, and they have these sparkling tires that are rolling, and you know, the way they are just decorated. But then you look at themselves when they disembark out of their vehicles, they have to come on wheelchairs that they are pushing. They're struggling. They can't even walk, you know, a significant distance. I talk about all these comorbidities we've just talked about, you know, high blood pressure, diabetes, obesity. It is basically because of the human organism that has suffered under the burden of inappropriate nutrition, I would say that. And so I'm challenging us, those of us in this conference, to say, I think we need to look back into the very fundamentals of our nutrition. And you know, right now we're dealing with, we're looking at the African Americans who are our brothers and sisters. And we wonder, you know, one of the things that amazed me when I landed in the aeroplane, of course, and I'm sure all of you can sort of, you know, resonate with this. When you looked at people and how their body sizes were just so huge coming straight from Kenya, I mean, it was a spectacle. And sometimes you would capture yourself just guessing at people, forgetting even the fact that, maybe somebody is watching you and wondering why you're staring at them, because it was a spectacle to watch the sizes of people here. But now we are here. We've been here 10 years now, 15 years, 20, and others have even been here longer. We're having children that are basically going in the same direction. I think it's time for us to go back to the original fundamentals of what human nutrition is supposed to be, so that we do not overload the system with cheap and empty calories, and soon we find ourselves in the same predicament. And that's why all these diseases, not just the pathologic ones from the infectious processes, but even the lifestyle, particularly that have ravaged the world. I just want to sound that warning to say I think it's time for us to return to the healthy nutrition, because a strong immunity means better health. Thank you so much for the opportunity to be part of this conference.
Thank you so much, Dr. Ngetish. Dr. Kanyari?
Oh, my final day, I would like to stress that initially it was thought COVID does not affect children, but of study now, we know it's affecting also a large number of kids. And even though they are asymptomatic, they can bring that disease to you. So it's very important to maintain CDC guidelines, you as a parent, even at home, because the kid might not be infected, but the kid might be infected, but not affected, and transfer the disease to you, especially if you know you have chronic diseases, as we've mentioned them earlier on. Thank you.
Dr. Kanyari, I just want to thank you. If you've not heard about Dr. Kanyari, I've had a lot of things from Georgia. She's actually one of the doctors who has been volunteering to treat patients for free. Is that correct?
Yes, yes, I do that. Mm-hmm.
So thank you so much. We really appreciate what you're doing that to serve our community, and especially to those of us, those who are vulnerable, they don't have insurance. And so we thank you for that.
Thank you for giving me the chance to be in this panel. Thank you.
Mm-hmm. Dr. Ngele?
So first, I want to thank all my fellow panelists and KESSA, everybody who participated in this. I think it's good for us to have these conversations and share ideas, because knowledge is power, and health literacy is very important in preventing chronic diseases and infectious diseases as well. And it's easy for us to sit here. Many times we like to use that term, or the African Americans, it's really us. It's like I said earlier, this is health equity is the civil rights issue of our time. We really have to join forces. We can work in small ways and big ways, but we have to fight this to make sure that our voices are heard, that there is a fairness, that we have opportunities that extend to others, whether it's through education, employment, and stuff like that, that allow people to advance. Because for a long time, this social injustice and segregation that's really not formal, that's been going on, put people at risk for diseases like this. And this has really served to show how interconnected we are. It's not a question of like, oh, it started in Wuhan, now we are the ones paying a very high price. It's affected the entire world. So we have to be advocates for more equity and opportunities for others, because until everybody is taken care of, none of us can be safe, none of us can be okay. So I really hope that in our communities, in big and small ways, we are able to educate people about health issues. You talked about nutrition, but a lot of the nutrition is lacking because we have food deserts. How do you fight to make sure we have fresh food stores in the neighborhoods? There is this segregation where you don't really get those, and all you can get is the dollar stores in there, the food that says not fresh. And even when it's fresh, can people afford to buy that? So we really need to fight together. We have to work together to change this. And one of the ways you make a difference is to vote. We are here, our children, and now people are organizing, but we just sit back. The only thing we do is go just vote for yourself, but you are not involved in organizing. This is our country, guys. I mean, we say we came here, we always want to think about we belong in Kenya, but we really are here. This is our home. We have to make it be a better place for ourselves and for our children, while also thinking about, of course, giving back home. So I'm happy that we are coming together and engaging with each other and really addressing the issues that affect our communities here in the US, as well as our communities in Kenya, because this is our home. Thank you very much.
Okay, thank you, Dr. Ngere, Dr. Kanyari, Dr. Ngetich, and now Dr. Molali.
Mine, first of all, is to thank the organizers for organizing this forum, and I think this is good, and you need to keep it up. This is my first one, and I think it was a learning experience, and at the same time, it gave an opportunity for me to share some of the what I have. I also need to thank the panelists for showing up and also being very resourceful. I think COVID-19 has opened a whole area of research. And for those ones who are either students or depending on whatever level, even up to PhD level, there's a wealth of research, because so much unknown about this COVID-19 that you can always find a research question and follow it up. It is just a few months ago, just 1 or 2 months ago, when we are all thinking that it causes fibrosis in the lungs and what have you. Until the Italians did the postmortems, and from postmortems, everything changed. We came to know that it is something which has got to do with the coagulation and intravascular, coagulation. So there's a whole area of research. And I must mention, there's going to be a baby boom. This opens another area of prospective study on these babies who are going to be born, and especially those ones at this time of COVID, at the peak of the COVID. So that's another area of study. And before I finish, draw your attention to what is happening in Taita Taveta within the KUP project. That is, these are 10 projects in one. And within those 10 projects, we are developing a medical hospital and a system. And we are requesting the doctors and the nurses in diaspora to be part of us in developing this hospital. It does not mean that you have to relocate to Taita Taveta. I'm sure for many of you that is far-fetched, but you can contribute in many ways. You might be working in a hospital which might be interested in becoming a collaborating center with us. You can introduce those people to us. You might want to participate in our distance medical care, telemedicine, because that is one thing we want to go into all that. So there's a lot you can do. You can also facilitate by identifying opportunities for training of our young doctors and nurses here. That way we are also most welcome. And over and above that, we are inviting people to come with ideas of small, medium enterprises, because one of the objectives of that university town is to create jobs. So if you want to set up an SME, you don't have to be in Kenya. You just come with an idea and you form a team in Kenya, and they will be able to manage that small enterprise. You create jobs and you'll be part of us. And one of the 10th project is a microfinance bank, which now we have set and is going to be having a branch in Boy. So that provides an opportunity for people in diaspora also to participate in the project. Thank you very much.
Thank you so much, Dr. Molali. I thought you stopped giving your fertility medicine. I didn't realize you were still busy during COVID.
No.
Okay, Before I turned over to my boss, I call him my boss. Dr. Patrick Mose is our vice president as well as the manager for, he manages our website. So if you look at that great website, please make sure you visit. Patrick is in charge of that, all the stuff that goes on there behind the scenes. Patrick is very instrumental. That's why I call him the boss there. Also, Ibala sent a message if you want to publish. You all are doing a lot of good research. Please get in touch go to the website and get the contacts for Imali. And now I hand over to Dr. Mose to give a vote of thanks and to invite to finish the meeting for us.
Okay, thank you very much. I know it has been a long day, but a very enjoyable day. I must acknowledge that I've learned a lot. Okay, on behalf of Kenya Scholars and Studies Association and the Governing Council, I would like to extend our hearty vote of thanks to our panelists, Dr. Ongeri, Dr. Kanyari, Dr. Ngetich, and Dr. Malali. Thank you very much. We really feel privileged to have you in the panel and for your contribution. And also I want to thank everyone who attended. We've had like more than 47 people. That's a very, very great number to have on such a day like Thursday. Yeah, and I just want to inform you that we'll be having KESSA Series, KESSA Zoom series every fourth Thursday of the month. I'm going to invite Pastor Ngetich to pray for us as we disperse.
All right, let us pray. We want to thank you, eternal God, again for the blessings of the gifts that we have in our midst. We want to thank you for all that attended and the wisdom that you've given to those that took part as panelists today. We know we have so much talent that is still within us, even as we meet in the next few sessions. We pray that you may be able to equip us continually as we bring these talents together. We also want to ask for wisdom that comes from heaven, because even as we get all this knowledge, we need to go beyond the knowledge to where we can come together. We can build and trust one another and work together, whether it is in doing research and conducting research and bringing it to the level where the world can be able to see. Otherwise, many times we've lost when the world comes and do patenting in some of the things we've already developed, because we were not organized enough, we were not together enough to be able to work in synergy. And so help us not only to know, but to be able to see the need of pulling together and coming together. I also want to pray for our families. I want to pray, oh Lord, even for those that are here going through this season. Some of them have already been infected. For those that are struggling, we pray that you may stretch your hand to touch and to heal. Protect us from harm and danger. We also want to pray for our country. And even tonight, Lord, as we part one from another, we ask that you may be able to guide each one of us, dismiss us not from your presence, but with your blessing as we go, because we ask all these favors as we thank you in Jesus' name. Amen.
Amen. Thank you, Pastor.
You can hang out. Dr. Ongeri is the after party boss. So you want to leave, feel free. But if you want to hang out and talk, Dr. Ongeri.
That's fine.